Good afternoon, students. This is Chapter 7, Anatomy and Procedures of the Toes, the Foot, and the Calcaneus, often known as the heel. So we're going to go through the same standard format that we usually use for procedures, lectures, and procedures modules. We're going to start out with a review of the anatomy of the foot in this case, but any radiographic exams or positions or procedures, we'll do a walkthrough of the anatomy of those particular body parts. So we'll be covering the anatomy of the foot, the heel, the tarsals, the metatarsals, the phalanges. So a lot of overlap in the terminology, especially the phalanges between the hand and the foot. General procedure considerations for radiographic exams of the toes, the foot, and the heel. Typically, it's still jewelry on occasion. Ankle bracelets, toe rings. Toe rings have fallen out of fashion, as far as I know, but on occasion you will see those. So those, obviously, shoes and socks would have to come off if they're able to. You're also going to want to wear gloves for these exams, as the toes, the feet, and the heel are often neglected by our patients, and various skin disorders, fungal infections, things of that nature can be involved in toes, feet, and heel examinations. So, general radiation safety and protection practices, no reason not to shield each and every patient for toes, foot, and heel exams. The reproductive organs are well away from the anatomy of interest, and so there's no reason not to deploy a shield. For your pediatric patients, the shield will actually help hold the patient still. Proper use of positioning aids. A 45-degree angle sponge is going to be beneficial to use for your geriatric non-ambulatory patient for proper positioning of some of the obliques and maybe the lateral projections. Okay. The simulation of exams, we will of course do a laboratory session on this. I'm not sure if it's I think it's the second week back. The first week back, we jump back into the shoulder. And so with the anatomy review, I'm not sure if this is going to play inside the recorded lecture, but it's the dead foot scene from Mr. Deeds, which is hilarious. If you haven't seen Mr. Deeds, go see Mr. Deeds. But basically, Adam Sandler has a necrotic foot, it looks like, and he offers his butler to stomp it and says he won't feel a thing. So.
That's Hawaiian Punch.
That's Hawaiian Punch.
He adores Hawaiian Punch. Wow! He kind of just snuck up on me there, man.
All right, so you guys can watch that in your own time. So the foot, in particular the anatomy, difference in thickness. The heel section of the foot, or the section of the tarsals, is 3 to 4 times the thickness of the section of the distal anatomy, the distal phalanges. And so the entire body part tapers from one end to the other, and so it's very hard to, especially setting a KV, it's hard to set a technique that adequately penetrates but does not over penetrate the other half of the body part. So for example, if you wanted adequate penetration of the toes, you would probably use 65 kV, 60 to 65 kV for the toes, but adequate penetration through the heel is going to be all the way up at 80 kV for our plantar-dorsal projection, and when I show you that. So quite a huge difference in kV ranges from one side of the foot to the other. And so just be mindful, because the body part increases in thickness so rapidly or so considerably from one end to the other, it's very difficult to capture the entire thing optimally. You will either adequately penetrate the phalanges and therefore underpenetrate the talus or the tarsal bones, or you will adequately penetrate the tarsal bones and overpenetrate the phalanges. And so that's just one of the problems with it. Was worse in screen film technology than it is in the digital age, but it is still a present difficulty with good images of the foot. You can either have good images of the toes and the metatarsals and the phalanges, or you can have good images of the tarsal bones, but you can't have both on the same projection, same radiograph. Okay. There are 26 bones in total. You're going to find 14 of those are phalanges, same as in the hands. Great toe, just like the thumb, only has 2 phalanges, and the other digits, 2 through 5, have 3 phalanges each. And so again, we have an interphalangeal joint in the great toe and a pip and dip joint in digits 2 through 5. Okay. All of your interphalangeal joints are diarthrotic hinge synovial type joints. Okay. So they all have a fluid space and they all flex and extend. Okay. And there's at least one weirdo in every group that can pick up their car keys or sign their name with their foot. And that's because a lot of the motions of the foot, it just takes practice. A lot of the motions of the foot and the capabilities of the joints of the foot are very similar to the capabilities of the joints in the hand. The most notable difference is the great toe is not in opposition to the other toes, like the thumb is in opposition to the fingers. So it would be even more similar. The foot would be even more similar to the hand if the great toe was in opposition, but it would make it tricky to walk on, I suppose. All right, so beyond the phalanges are the metatarsal bones. There are 5 of those. The first metatarsal also has 2 sesamoid bones at its distal end. And just like the metacarpals in the palm of the hand, there is a base and a head to the metatarsal bones. Digits again are numbered 1 through 5, similarly to the hand. We often call digit number 1 the great toe rather than digit number 1. So the distal ends of the metatarsals will articulate with the phalanges, forming the MTP joints, not the MCP, the MTP joints. So we still have dips and pips, but then we have metatarsal phalangeal joints. The metatarsal phalangeal joint of the great toe is actually what you know as the ball of your foot. MTP joints are ellipsoidal in motion, very much like the metacarpal phalangeal joints of your hand. Beyond the metatarsals are the tarsals, or actually in front of the metatarsals are the tarsals. There are 7 tarsal bones in all. The most superior one is the talus. The most posterior one is the calcaneus or os calcis. That's also the biggest one. It's called the heel bone. And then there's a cuboid, which resembles a cube, and a navicular. And then wrapping up the tarsal bones, there are 3 cuneiforms, just distal to the navicular, and those are the first, second, third, or internal, middle, and external. I've even seen them called medial, intermediate, and lateral. So depending upon what textbook you encounter, there are several different names for the naming of the cuneiforms, but typically the numbers start with the medial side, which is the side of the great toe, and then move to the third one, which is at the midline of the foot. Our calcaneus, its largest tarsal bone, it is bordered or articulates with the talus bone, superiorly, inferiorly, and then it articulates with the navicular bone as well, more anteriorly. Okay. It has 1, 2, 3, 4. I think it's got 4 facet surfaces. Anterior articular facet, medial articular facet, and then posterior articular facet. I think there's an unnamed articular facet below the anterior articular. I guess that would be I would call it the navicular articular facet myself. The posterior articular facet is the union with the talus bone that sits on top. The middle and anterior articular facets, I think those are also the talus bone, but I'm not certain of that. Okay. There is a slight bulging to the base of the heel. That's called the tuberosity. And just below the tuberosity is the site of the most common site of fractures is just underneath the tuberosity. I dare call it the neck of the heel bone. But typically a heel fracture involves the tuberosity collapsing in on the body of the heel in like a crushing injury. Right, the talus bone is the second largest of the tarsal bones. The talus articulates with the calcaneus to form the subtalar joint, which is also part of the sinus tarsi space that we'll see on some of the radiographs later. The anterior surface or the superior surface of the talus bone articulates with the tibia to form the ankle joint. Our cuboid bone on the lateral aspect of the foot is a bridge between the heel bone and the metatarsal, the 4th and 5th metatarsals. Okay. It's called a cuboid bone because it's shaped like a cube. It's best visualized in the medial oblique X-ray of the foot, where you can see all of its borders, all of its articulations, and you can see its shape as a cube. On the opposite side of the cuboid, the navicular on the medial aspect of the foot is in between the cuneiforms and the talus bone and the calcaneus. So the cuneiforms don't actually articulate with the talus and the calcaneus. The cuneiforms articulate with the navicular. Okay. The cuneiforms, 1, 2, 3, medial, intermediate, lateral. Also internal, middle, and external. So three different names, three different sets of names for the same bones. Again, just have to be mindful of the author. The medial cuneiform is the largest of the cuneiforms, and the intermediate is the smallest of the cuneiforms. Okay, and so proximally to the cuneiforms is the navicular bone. Distally is the metatarsals. First, second, and third metatarsals are distal to those cuneiforms. Okay. And then again, I mentioned the sesamoid bones. Those are found on the plantar surface, the underside of the foot, the sole, the sole of the foot, at just, well, sometimes they're described as at the metatarsal phalangeal joint of the great toe, sometimes described as just proximal to that joint. Everyone has, at the ball of their foot, two sesamoid bones on the underside of their great toe. And you can fracture those, what it looks like. All right, so when we get around to taking x-rays, patient preparation, your patient's going to be either standing or on the table. Typically, you have them remove, shoes and socks for the x-ray. If they're in any kind of splint or boot or cast, make sure we're getting permission to remove any supportive structure or any fixation structure before we take those x-rays. General patient position, again, seated or standing. Trauma and post-fixation, you're probably going to want to do them seated on the exam table or in a stretcher portably. IR collimated field size, you shouldn't need larger than, well, maybe in extreme circumstances you'll need larger than 10 by 12, but most folks will fit on a 10 by 12 image receptor or 10 by 12 field of view. SID is standardized at 40 inches. You should get good alignment of the body part to the image receptor and a close proximity of the affected anatomy to the image receptor in most cases. And so we usually don't have to increase the SID to fight any kind of magnification or distortion. ID markers, yes, your patient has a left and a right foot, and there's a very distinct difference between those two. You should be using radiopaque ID markers. I've already mentioned for radiation protection that you should shield everybody. In addition to this, close collimation and attention to detail when centering and positioning to prevent repeats. All three of those are good radiation protection practices. For your patient instructions, you're going to need them to hold still. Some of the positions are uncomfortable for some of our patient populations, and so we'll just have to watch that. Remember, a comfortable patient is going to hold still better than an uncomfortable patient will. Right, so first thing is for x-rays of the toes. Typically, you're doing an axial projection with a 15-degree angle, centering to the metatarsal phalangeal joints, and then opening to the base of the metatarsals bones. So the metatarsal, tarsal articulations. So open to the cuneiform, so the bridge of the foot, essentially. Okay. A 15-degree angle directed toward the head, so it is a cephalid angle. If the patient's leg was extended, the general direction of that tube angle would be toward the head, away from the feet. Okay, you're going to want to bend the patient's knee. If they're on the table, bend the patient's knee, flex the knee, and put the foot down, plantar surface down on the image receptor. This particular picture, they're doing 2-on-1, so they're covering the other side of the image receptor with lead rubber. We've figured out now that in the digital age there's no advantage to that, and it actually can produce a processing error. So I encourage you to do just one exposure on one image receptor and process. Don't do 2 on 1 exposures. Okay. The long axis of the foot is parallel with the long axis of the cassette. Open the collimated field to include the end of the toes all the way to beyond the bases of the metatarsal bones. The base of the 5th metatarsal is a tuberosity that can be palpated to evaluate the size of the field of view, the light field itself. All right. So this is what the radiograph will look like. By employing that 15-degree angle, they call it posterior, but it's a cephalad angle. By employing that 15-degree angle or elevating the toes on a 15-degree wedge sponge, you're going to open up the dip and pip joints on the 2nd through 5th phalanges, even the great toe. You're going to open up dip, pip, and metatarsal phalangeal joints. Now, if you're doing all the toes, you do want to center at the 3rd MTP joint. If you're doing an individual evaluation, just center at the MTP joint for the particular toe that is the area of interest. But you should be using that 15-degree angle. The 15-degree angle opens up the joint spaces, makes it so you can visualize the interphalangeal joint spaces and the metatarsal phalangeal joint space open on the radiograph. Okay. For oblique positions of the toes, collimation is about the same. We're going to reduce the tube angle to 0. We want a perpendicular tube angle this time, and we're going to medially rotate the foot 30 to 45 degrees internally. Okay, so rolled onto the great toe. You can use an angle sponge for reinforcement, but most of your patients will be capable of this maneuver, even with limited flexibility. They'll be able to medially oblique the toe. If they're on the table, laying down, flex the foot, put the plantar surface on the image receptor, and then roll the patient onto the big toe until the plantar surface forms about a 30-degree angle with the plane of the image receptor. No tube angle. So we go from, when we shoot the AP, remember it's an AP axial, so we'll go from a 15-degree tube angle for the toes for an AP to 0 tube angle for an oblique. Okay. Again, we're centering to the metatarsal phalangeal joint. Again, you want to open the collimation to include all of the metatarsal bone back to the tarsals, back to the cuneiforms. And the base of the 5th metatarsal is palpable, and that can give you a palpable landmark as to how far the light should extend. It's also the site of a common fracture that we'll get to later in the lecture. So it's always a good idea to include your light back to the base of the 5th metatarsal, because that's a common site for fracture in the foot. Okay. Lateral, great, and second toe. The instructions for this is very much like the instructions for the lateral fingers were different. You would, for the 2nd and 3rd digit, you would medially rotate the hand. And then for the 4th and 5th, you would laterally rotate the hand. The same thing's going to happen for the toes. You want to isolate the toe, the great toe. You're going to have to roll the patient medially with the great toe down against the image receptor, and then try to isolate it with tongue depressors and tape and gauze, things of that nature, to separate the affected toe from the other toes and really try to remove as much superimposition as possible. Direct your central ray again to the metatarsal phalangeal joint. Okay? And just roll the patient's foot up on its side, either the medial edge or the lateral edge, depending upon which toe you're isolating and which toe is the area of interest. Open the collimation back to the bases of the metatarsals, to the cuneiforms, to the midfoot. Okay? And I'll show you where that is in the lab. Okay. And yeah, the isolating is some patients do it better than others. The patients that can pick up pens and dropped items with their foot seem to have greater flexibility when you come to positioning the lateral, and they can isolate individual toes and spread their toes a little bit better than other folks. Of course, if their toe has been bashed and it hurts, you might not get good separation at all. Okay. Lassoing the unaffected toes with tape and pulling traction on them in various directions, either superiorly or inferiorly to the plane of the foot, can create good separation in most cases. Okay, so there we go. We've got a wad of gauze stuffed in between the great toe and the second digit, and that isolates effectively the great toe. There you see the medial edge is down to reduce OID, so the area of interest in that top left one is the great toe. Looks like we have a tongue depressor being used to isolate the second digit, again medial side down. Okay. But if we're trying to isolate the pinky toe, a tongue depressor or a wad of gauze, and now a lateral aspect of the foot is the side down for the fifth digit in lateral in the bottom left, right? So a couple of variations in positions and variations in how you set up and position the anatomy relative to the rest, because the whole idea is to isolate and remove as much superimposition as possible. And from a lateral perspective, what's in the way? Well, all the other toes, that's what's in the way. And so you have to pry the affected toe away from the rest of them and fix that in place with either a tongue depressor or gauze, or sometimes a tourniquet strap can be used to isolate a toe. You just pull a little bit of tension with a tourniquet strap and it will separate from the other toes. Some of your patients will be able to flex the remaining toes downward while sticking the big toe or pointing the big toe back toward their head, like we see in the radiograph. Okay. Anytime you're using a tongue depressor or a wad of gauze or a tourniquet, a little rubber strap, do remember that there is going to be some artifact by using those fixators, those positioning aids, but it's usually better than not achieving the separation. Okay. All right, moving on to the more common radiograph. We usually don't get toe radiographs as much as we get feet radiographs. And so for an entire foot, now instead of using a 15-degree axial projection, we're going to do a 10-degree for a foot. So 15 for the toes, 10 for the feet. Just memorize that phrase. 15 for the toes, 10 for the feet. Okay, so an AP axial foot features a 10-degree cephalad angle with the foot resting, again, plantar surface against the image receptor, and now we are centering to the base of the third metatarsal, which is right in the middle of the foot. It's halfway between the left and the right side of the foot, the medial aspect and the lateral aspect of the foot, the toes and the heel. So just find the halfway point between the toes and the heels, find the halfway point between the medial edge and the lateral edge, and you should be right at the base of the third metatarsal in your centering. Align the long axis of the cassette with the long axis of the body part. Obviously, open your collimated field so you're not clipping the toes. The heel can actually be clipped off in this projection. It's not considered pertinent anatomy. It's superimposed by the tibia and the fibula and is not usually well demonstrated on the AP axial foot. On the oblique foot, the heel is actually part of the anatomy, and so you'll have to extend the collimation to include the heel in an oblique display. Okay, so our medial oblique foot, again, 30 degrees of internal rotation, very much like the medial oblique toes. The plantar surface intersects the image receptor at 30 degrees. Again, we don't have a tube angle anymore, so we've lost the 10-degree tube angle. So when you're doing a foot series, you're going to do an axial foot with a 10-degree tube angle, and then to do the oblique, you're going to reduce the tube angle to 0, and then rotate the body part 30 degrees medially. Rolled onto the great toe 30 degrees. It's going to open the spaces between the metatarsal bones. So the inner metatarsal joints are going to open up, especially the third, fourth, and fifth digits. The spaces in between those are going to open up really well. The spaces around the cuboid bone are going to be best demonstrated on a medial oblique foot. And we do see a nice oblique view of the calcaneus bone. The nearest we get to an AP view of the calcaneus bone without the tibia and the fibula kind of roll medially, and so we see less superimposition. There's still some superimposition, but less superimposition than we do for an AP axial foot. So include the collimation all the way back to the tuberosity of the heel. For our lateral foot, patient laying on the table or a cross table projection for a standing exam. You will need a special support device with a groove for your cassette so that the base of the cassette can get lower than the base of the foot. I'll show you what I mean when we get over in the exam. We do have a standing platform for a cross table foot, and I'll show you how to do a standing cross table foot. The centering is the same regardless of whether you're standing or laying down for a lateral foot. It is centered to the very middle of the foot. It is between the heel and halfway between the heel and the big toe, halfway between the top of the foot, that is the bridge of the foot, where your shoelaces are, the bridge of the foot, and the plantar surface of the foot. Okay. The plantar surface through the metatarsal phalangeal joints should be perpendicular to the image receptor. The metatarsal phalangeal joint should be in the same plane as the base of the heel. Now the arch might move out of that plane, but you should see a nice vertical plane to the most of the plantar surface of the foot. You might have to elevate the knee ever so slightly, a little angle sponge or maybe a rolled up sheet under the front of the knee will bring that plantar surface to a true vertical and get you a true lateral of the foot. If the plantar surface isn't vertical, you technically have an oblique foot. You don't have a true lateral of the foot. The patient needs to dorsiflex the foot to open the ankle joint and also to open the sinus tarsi and to get the foot in true lateral and the metatarsal bones superimposed with each other. Dorsiflex the foot, and that will assist you with getting the foot into a true lateral. Okay. And so our radiographic signs for quality lateral foot, we want to see an open sinus tarsi, open ankle joint. We want the ankle joint included. We should see complete overlap of the metatarsal phalangeal joint, or the metatarsal bones themselves, 1 through 5, should be superimposed with each other. Very much like the metacarpals in a lateral hand should be superimposed. Okay. Should see open metatarsal phalangeal joint spaces should be open. Collimated edges, you should be beyond the tips of the toes, the distal phalanges, but you should also include all of the heel, including all of the soft tissue structures of both the toes and the heel, the entire soft tissue of the plantar surface also, because that's an area of high pathology typically too, is the soft tissue injuries to the plantar surface are very common. Okay, the entire ankle joint and about an inch and a half of anatomy proximal to the ankle joint. So the distal end of the tibia and the fibula should be on the radiograph. Okay. This is a very good true lateral of the foot. All right, our axial plantodorsal calcaneus projection, or os calcis projection. This one is tricky because the way the tube angle is described, very much like the Gaynor-Hart method, the tube angle is 40 degrees to the plantar surface. Remember how the angle for the Gaynor-Hart was 35 degrees to the palmar surface. This is 40 degrees to the plantar surface. Now you can do a plantodorsal or a dorsal plantar, like you see in the bottom radiograph. As long as the plantar surface is vertical, the tube angle is the same as the angle to, well, it's actually 50 degrees to the image receptor, 40 degrees to the vertical, okay? And I'll show you how that works. So extend the foot, dorsiflex the foot, the ankle bone should be, or the ankle joint rather, should be in a right angle with the plantar surface as vertical as possible. You might have to use a traction device, like bands of tape around the ball of the foot, and have the patient pull back on their toes. Okay? We're going to direct the central ray to the level of the base of the fifth metatarsal, which is at the midfoot. And that's because the joint space between the calcaneus, the subtalar joint, between the calcaneus and the navicular is revealed at the midfoot with this 40-degree angle to the plantar surface, which is, it basically gives us the information as to whether or not the heel has dislocated from the other tarsal bones. Now the plantodorsal calcaneus projection also tells us about a crushing fracture or a collapsing fracture to the heel, which is the most common fracture of a heel. The tuberosity kind of caves in on the rest of the heel. And we'll also see that on this radiograph. Okay. So this is what a plantodorsal will look like. There's a faint black stripe right about in the middle of the radiograph there. That is the subtalar joint and the articulations of the calcaneus with the talus and the navicular bones. Okay. Collimated field, you want all the soft tissues surrounding the heel, and you want the collimation open back to the base of the fifth metatarsal. Okay. It says that the central ray enters the base of the third metatarsal, but the only way you're going to find that is if you palpate for or look for the tuberosity at the base of the fifth metatarsal, and then aim for that same plane, that same transverse plane or axial plane going through. So, and I'll show you how it looks in lab, so you can shoot a proper axial foot. Markers should be at the distal end of the heel, right where this marker is. That's great. Remember that this is a 40-degree angle, so the anatomy is being thrown quite a bit across the image receptor, and there's quite a bit of elongation too. And the marker is subject to the same distortions. So the marker, the shadow of the marker will stretch a little bit and will shift a little bit in position on the x-ray. So just be mindful of that as you're placing your marker. Don't get too close to the shadow of the heel. To do a lateral calcaneus, you're going to center 1/2 inch below the ankle joint with the patient laying down. That's 1/2 inch distal to the medial malleolus, okay, which is the bump that marks the ankle joint. Okay. Open your collimation anteriorly to include the base of the 5th metatarsal bone, because again, that's a common site of fracture. We do also want the plantar surface to be vertical again, so dorsiflex the foot again, and possibly prop the knee up ever so slightly to bring the plantar surface into a vertical orientation or perpendicular to the cassette. Okay. When you're doing a cross-table lateral for a heel, try to support the body part not at the heel but at the ankle. Build it up on a stack of pillows or bed sheets at the ankle. Let the heel kind of float out in space with a vertical standing cassette. And you can shoot lateral medial or medial lateral for that cross table heel projection. And I'll show you how to do cross table foot, heel, and toes when we get to the positioning lab. Here's our common fractures, and you might remember Derrick Henry actually had this either 2-3 years ago. It's called a Jones fracture. It's where you chip off the tuberosity on the base of the 5th metatarsal. Okay? It's best revealed in the medial oblique foot, but it also shows up on the AP and the lateral. It shows up ever so clear because all the superimposition is removed on the medial oblique foot. So, but you'll see it on the lateral, and you'll see it on the AP axial as well. So one of the more common fractures of the foot, the Jones fracture. Additional fractures of the foot usually involve either stepping on something or getting the foot crushed by a heavy object. And so you typically see transverse fractures of the metatarsals and or the phalanges. And if it's a crushing injury, usually it's the entire foot that you'll have to x-ray, not just a singular toe. Okay, those are the positions and the projections for the toes, the foot, and the heel. We did a series of 3 for each of those. Well, except for the heel, we did a series of 2. We did a planodorsal and a lateral. But it's a 3 series for a toe series. It's an AP axial, AP medial oblique, and a lateral. And same for a foot, AP axial, AP medial oblique, and lateral. Remember, 15 degrees tube angle for the toes, 10-degree tube angle for the feet. No reason not to shield. Use the angle sponge for positioning for your elderly patients and patients that can't hold still, can't hold the position. Use tape, gauze, and tongue depressors to isolate toes on lateral projections and sometimes on oblique projections. And use tape or a bed sheet for dorsiflexion, for traction, additional traction for dorsiflexion if the patient struggles to dorsiflex for your lateral heel and your lateral foot x-rays. So, and I'll demonstrate all those to you when we get to positions of the toes and the foot, which we'll get to probably straight away, right after we rehash on the shoulder. We'll get right into that week 2 of January. So looking forward to it. I'll see you guys in the lab. Take care.